Donc I'm going to continue talking about clinical applications of diffusion IVIM. Just to start for background, it's been already covered by the excellent talk before. Just to remind you about what diffusion is, it is due to thermal agitation of water, like you can see here on this picture on the right. And in tissues, the water interacts with a lot of elements. That includes membranes, intracellular elements, extracellular elements like, for instance, collagen. And what you measure is called the ADC, or apparent diffusion coefficient, which is typically several-fold less than in pure water. So typically in tissues, the ADC is going to be low compared to typical ADC in water, which is about 3×10⁻³ . And as was suggested before, diffusion quantifies water motion and capillary perfusion as well. Typically, when you have free water diffusion, typically it's a cystic, tissue, or a necrotic tissue, or a benign lesion, for instance. Typically, the water moves kind of freely. And when you have complex tissues with high cellularity, like shown here on the right, in the tumor, for instance, there'll be more hindrance to the water motion because there's all these elements, and the ADC typically goes down in these tissues. Typical applications of diffusion, there's a lot of papers on this, looks at the ADC, which is a simple mono-exponential fit of the signal intensity of the tissue function of the B-value, which is something you can control on the system. Typical non-cancer tissue will have a strong signal attenuation, shown here on the green line, and cancer tissue will have minimal or no attenuation. And then if you measure the slope of that curve here, that represents the ADC. So it's quite easy to quantify. You can do it either by measuring signal intensity, or you can just get ADC maps, which is done nowadays by any system. Basically, it gets you voxel-based ADC maps. This is an example of a prostate cancer with diffusion. You can see as you increase the B-value from 0 to 1,000, you're going to see the tumor as bright. In fact, the signal is not increasing. The signal is decreasing a little bit, but the background tissue is decreasing. So there's a contrast that increases between the tumor and the background tissue. And then the ADC gives you the exact opposite of what you see with a high B-value. So it's going to be dark on the ADC map. So typically we use single-shot API sequences in most clinical applications with fat suppression. Typically, we use either bipolar or monopolar gradients, shown here. So this is how you sensitize your acquisition to diffusion. And you can see, again, the diffusion signal attenuation with the ADC. And again, this is the equation for the ADC. It's quite simple. Now, what are the limitations of ADC? So there's some variability of the values you're getting with the selected B-values, so that makes the comparison of different studies that use different B-values very difficult, in fact. So that's one of the issues. And there's also a perfusion contamination in the ADC values, which we're going to talk about in a few minutes. So there is really a lot of interest in clinical applications for looking beyond ADC. And trying to kind of separate the perfusion effect and maybe the kurtosis effect as well from the real diffusion, true molecular diffusion effect. So that comes, then we're going to talk here, the heart of the subject is to talk about IVIM, or intravoxel incoherent motion, DWI, which has been initially described in 1998, and I think 1988, I'm sorry, it's a mistake, by Denis Le Bihan back for brain imaging. So there's a lot of hopes in looking at flow in the brain with IVIM, but in fact, what happened in the brain was that there's a lot of contamination from the CSF flow, basically, and then it kind of decreased in interest. But now it's coming back because there's very strong tools to quantify this. There's also a lot of new applications outside the brain, which makes it really more interesting. I'm not saying that brain is not interesting, but there's more interest outside the brain. So if you use multiple B-values, you're going to get an inflection, initial inflection of the signal decay, as shown here on this green curve. And that inflection generally is seen in very vascularized tissues, like the kidney, for instance, or the liver, or in tumors that have a lot of flow. in them. So this is what we call the pseudo-diffusion decay or pseudo-diffusion effect. And then you can really, if you look at the curves, in fact, you can really construct 3 new parameters. The easy one is called D or DT, which is stands for true molecular diffusion. So this one is easy to quantify. Actually, you basically use any b-value above 200 to minimum, and then you get a mono-exponential fit of that, and you get the true molecular diffusion, as long as the highest b-value is not too high, because if you're getting too high b-values, then you're getting into the kurtosis effect, which you don't want to. If you look at the early inflection here, if you continue this curve to the y-axis, you're going to get an intercept. The difference between the intercept and the true signal is what we call perfusion fraction, or F, PF or F in papers. This reflects the fraction of protons in the capillary system. And then the curvature itself is given by what we call D star, which is the pseudo-diffusion decay. So obviously this is more complex compared to the mono-exponential decay, and this is the equation here shown here. So there's 3 variables you're trying to solve. So I'm not going to get into the details of how you do this. There's different ways. I'm going to show you one slide on that. So one of the drawbacks for a clinical application is that you need more time, right? You need to sample more b-values. So that means you can't just do it in a breath hold, for instance, anymore, because you need to acquire at least 5 or 6 b-values. So that's one of the drawbacks of IVAM clinically. So basically, these are just, a potential explanation of what we're measuring here. With D or DT, we think we measure tissue structure, maybe cellularity. With PF or F, perfusion fraction, that likely represents the blood volume of the tissue or vascular volume. And D star is a little more complicated to understand, I think. That probably reflects the blood flow velocity or spin velocity in the tissues. And in our experience, it's been the most unstable parameter. It's very hard, actually. It's not robust enough to be used in clinical applications at this point, not yet, at least. I'm going to show you why. So again, multiple b-values is important. You need to have a lot of b-values below 200, which typically in clinical applications would do 0 and something. Here you have to do a lot of them before or below 200 in order to quantify with robustness, with good accuracy, PF and D star. You need a small number of b-values above 200 because, again, remember, you just need a line for D or DT, so it's easy enough. You can do free breathing or respiratory triggered application for the abdomen. You can do free breathing for the pelvis. The number of averages will depend on the b-values. So typically, on your new systems, you can really modify the number of averages for each b-value, which is really important because you don't want to increase the time. So for low b-values, you can just get away with low averages. But then if you hit high b-values, then you got to hit low SNR. Then you need to increase the number of averages. The optimal number of b-values is undefined. And there's some literature on it, not a lot, and it's probably a minimum of 4 or 6. So this is an example of how we do the acquisition. We've been doing this for liver imaging mostly, and so for prostate. And recently we started looking at kidney as well. So this is a coronal acquisition with 16 b-values, about 8-minute acquisition. This is also 16 b-values, free breathing, 3T. So there's a question about field strength. You can do 1.5 with 3T. I mean, the numbers should be really more or less equivalent. There's some variability, but minimal. And this is an HEC. This is how you process the data. There's 2 ways always for parametric imaging. You can do ROI-based, a region of interest, or you can do parametric-based. And I think at this point, we've been doing IVAM for like 4 or 5 years now. We don't feel there's enough robustness in the parametric maps to use them for our research. So that's why it's really important that vendors propose solutions that are stable and robust enough that look good. So at this point, we've been using ROI-based methods, which are more stable. And this is an example of how you do a measurement in the liver, for instance, or the kidney cortex. And you can see a nice fit here of the IVAM data. Timothée talked about the Bayesian method versus least squares. This is really a kind of technical detail, but you can probably do both ways. Our preference is for Bayesian methods, which estimates also the parameter probability. There's much more, it's probabilistic method, basically. It's more stable. It's been initially developed by the group at the Marsden, and we've been able to work with them on this. At the end, we didn't find major differences in the numbers for the liver at least, but we feel it's a more robust method for IVAM quantification. There's also something we start doing also, which is proposed also by the group by David Collins and Matthew Orton at the Marsden. They're proposing to do a TE correction. So you have to do an IVAM with 2 TEs to correct for the TE effect as well, which is really something that just emerged recently. You can do functional maps. These are homemade maps that we did on MATLAB. So you can see, for instance, in this case, differences between normal liver and cirrhotic liver for true diffusion and also for perfusion fraction. You can see decreased perfusion fraction. You can see here, if you pay attention to the D-star map, it's very noisy. That tells you how unstable D-star is for parametric estimation. And then also for HCC, I showed you a case already. So this is an example. This is given to me by OLIAB, by Bruno Trier. So you can see also here large HCC in the liver with some parametric maps based on, you can see again, D-star seems to be really extremely noisy, like showed on the previous slides. This is an example for prostate as well. So I'm going to talk a little bit about how many b-values you need. There was, for instance, a paper in JMRI from a French group looking at 4 b-values for liver imaging. They found it was good enough. 0, 12, 80, 800. I'm not sure why they used 12, why not 10, but so 3 below 200 or below 100 and 1 above 200. In our study, this is published last year, we started with 16, and we basically did multiple simulations from 16 down to 3 b-values, basically. So this took us like, I don't know, 10,000 different combinations, basically. And we observed that 4 b-values should be good enough, like 0.15, very close to what has been proposed by this paper. Again, 1 b-value above 200 and 3 below 200 to really estimate the IVAM parameters with acceptable error margin. And this, obviously, if you do 4 instead of 16, you decrease your acquisition time significantly from 8 minutes to like 2-3 minutes. So this is showing you, this is the error, you know, in the estimation. You can see if you go from 16, if you go down to 6, your estimation error is going to be acceptable, below 20%, basically, for at least for DNPF. I mean, for D-star, the error is going to be high anyway. And we don't pay as much attention to D-star at this point, but for D and PF, it's okay to go with 4 b-values. So this is some examples with different b-values. Again, no major differences visually between 16, 12, 8, and 4. No major differences in PF, and again, D-star very noisy. So we feel that, you know, at least 4 is the minimum you need to use for for clinical performance. So next few minutes, I'm going to talk, I don't know if I have 5 minutes left, so talk about the evidence now. What is the scientific evidence? This is really nice. I mean, you can do nice curves, you can do nice maps maybe, but is it really helping me clinically? So for liver applications, there have been few papers looking at characterization of focal liver lesions with IVIM, because we know that ADC doesn't perform as well as we want. There's an overlap. And in fact, there's some mixed results. There's, for instance, two papers showed that there is no interest, no added value in doing IVIM for liver lesion characterization. But there's one paper, a Korean paper, that showed that D was slightly better, true diffusion was slightly better than ADC. So this has to be really verified in more studies. There's also some data looking at liver cancer grade, tumor grade, and there's a paper showing a negative correlation. This is a paper by SNUH in Seoul, in Korea. There was a negative correlation, and they showed that there was a very good AUC in differentiating high grade from low grade HCC using D, for instance, compared to ADC. So again, this is only a single study. There's no more studies. In our experience, we're still acquiring data. We don't feel there's a correlation with grade. And at this point, we did about 20 cases, but we're still enrolling more patients. There's also some correlation with the degree of enhancement. So the interest of also IVIM is, say, can I replace it? Can I replace the enhancement? Can I just get rid of the contrast and just do diffusion? with IVIM instead of injecting the dye, which is a good question, good, useful if it works. But then the correlation is variable, actually. So I'm going to show more data from our group. This paper in 2014 showed some correlation with enhancement, but it's not a great correlation. So clearly, we're not measuring the same thing. Prediction of tumor necrosis also seems to be also interesting. According to two initial studies, there's some correlation between true diffusion, and tumor necrosis. I think I'm going to pass this one here. So this is our recent experience. This paper has been submitted. We looked at about 80 HCCs with enhancement, like with regular enhancement, and we found only very weak correlations, basically, between IVIM and an enhancement. So there's clearly non-redundant information from the two. And we found that also necrosis was easily detected, was well detected with diffusion, if you want to look at that. But for the enhancement, there's really not much in terms of correlation. And this is a more recent, actually, data we're just working on right now. This is where we looked at IVIM and DCE-MRI. So here we're doing perfusion imaging, right? We don't do just 4 time points. We're doing perfusion for like 3 minutes. So we have real perfusion and flow data in liver cancer and also in liver parenchyma. And what was interesting here is that this is not published, but what was interesting is that there was some correlation between IVIM and perfusion in the liver only. And remember, the liver has mostly portal venous flow inflow, but there was no correlation in HCC, which is most of the time perfused by the hepatic artery. So there's clearly something there. So it seems that PF, perfusion fraction, is more sensitive to portal venous flow, according to this data, but not to arterial flow. And so maybe it's not good enough to capture neoangiogenesis or arterial flow, and we need to probably use both, maybe, to look for tumor response. We clearly cannot, it's not interchangeable. We cannot say that this EMRI can be replaced by IVIM at this point in liver cancer. So real applications, there's an interesting paper by NYU, actually 2012, where they showed that there is an increased perfusion fraction and decreased diffusion in enhancing renal neoplasms. When you look at the enhancement, there's a strong correlation. Again, it was a single study, less than 40 cases, not verified. There's also some more recent study looking at IVIM with differentiation of different subtypes of RCC. There's also more data that's older that looked at, for instance, renal artery stenosis, urinary obstruction. There's, for instance, some interesting data here looking at the perfusion fraction in acute obstruction from kidney stones. Showed no difference in ADC and D. That's interesting. And there's also a publication showing the effect of Lasix on kidney IVIM. All of this data is, again, very recent and not verified by other investigators. So it's really single-center data, sometimes not prospective, not verified by other centers. Pancreas is very little data. There's 2 or 3 papers on pancreatic IVIM. It's a study from Germany, for instance, showed that there's a possibility of using perfusion fraction to discriminate normal pancreatic parenchyma from neoplasm with higher accuracy compared to ADC or D, but we need really further studies here. For prostate, there's very limited data, surprisingly, because that diffusion is very important for prostate cancer evaluation. I found only 2 papers at this point that showed, one of them showed no correlation with Gleason score. We know there's some degree of correlation between ADC and Gleason score. There's at least 10 papers on that. And this paper showed no correlation between IVIM and Gleason score. And there's another paper that's smaller series that showed some degree of discrimination between low and high grade prostate cancer. Clearly, there's some contradictory results here, and we need to get more and more data for prostate cancer. At this point, it's not recommended to use IVIM for prostate cancer evaluation by ESUR or by the American College of Radiology. For the PIRATS classification, we just need 2 p-values, basically, to look at ADC. For tumor response, there's mostly preclinical data. The clinical data is very limited, very small. There's, for instance, this paper looking at vascular disrupting agent in VX2 HCC. This is a preclinical model, and showed that there's clearly an acute change in IVAM parameters at 4 hours that recovers at baseline. Obviously, this is really hard to do in humans because you need to image the patients a few hours after the intervention and then eventually sequentially. So it's very hard, but that's why it's interesting to have a preclinical model. But the translation to human tumors is really far from being clear. There's also some preliminary work in head and neck cancer that showed possibility of using pretreatment IVAM for prognostic in head and neck cancer. So I'm going to finish by telling you that when you do IVAM in the clinic, if you do it for a drug trial or for a research study, it's important to estimate your reproducibility, very important. This is done, for instance, by doing what we call the coffee break. So a patient comes in or a volunteer, gets scanned, gets the IVAM, and go get the coffee and come back, okay? So and then we scan them, we remove the coil, restart the whole screening process again, and then they come back after, say, an hour or half an hour. You repeat the measurement again, and you have to get, in theory, you have to get the same exact measurement, but obviously there'll be differences. And you can see here that the CV, which is the easy way to look at variability, which is coefficient of variability, is acceptable for diffusion, for D, for ADC, not so good for perfusion fraction and D star. You can see for D star it's pretty bad actually in tumors, about 60%. So that means if you want to use D star prospectively for a drug trial, you need to be looking at changes above 60%, at least above 60%. Okay, so I'm gonna summarize here this to say that the additional value of IVAM parameters over ADC is variable depending on the tissue or the lesion studied. It may have value in highly vascularized tissues like the liver, pancreas, and the kidneys, but there's more evidence is needed. And also the biological significance of IVAM-related perfusion, quote unquote, needs to be better understood. Thank you.